Okay. Hello, Dr. Kintade. Okay. Good evening, everyone. I'm Dr. John Afam, the trainee representative of the Nigerian Society of Anaesthetists, and I'm here to welcome us all to the 10th edition of the Residents Webinar Series. As is customary, we are grateful to the Nigerian Society of Anaesthetists for giving us this platform and this opportunity, with special thanks to the President-elect and the head of the Educational Committee, Dr. Quinet Kalu, and the President of the NSA, Prof. Hassan Dati. So, without further ado, we will commence shortly because we already have over 30 people online. I'll be introducing our moderator for the day, Dr. Bolanle Salahuddin, a senior registrar from the School of Anaesthesia Studies in Badagry. So, Dr. Bolanle, you have the floor. Welcome, and thank you, everyone, for joining in.
Good evening. Dr. John, am I audible?
Oh, yes, you're loud and clear.
Okay. I'm Dr. Salahuddin Bolanle, Senior Registrar, Department of Anaesthesia. As I've been introduced, I worked at General Hospital, Lagos. I want to welcome everyone on board, and I want to appreciate the President, Nigerian Society of Anaesthetists, the NSA Executive, and the Board of Trustees for all the privileges given to the residents to learn and improve on our academic and clinical performance. And I also want to appreciate them for nominating me to be the moderator for this academic session holding this evening. So this evening, Dr. Adeboye Akitade, Registrar for Department of Anaesthesia, Federal Medical Center, Ebute Lagos, will be leading a discussion on the topic anesthesia management of the polytraumatized patients. While the presentation is ongoing, I encourage all the participants to please mute mic of their device and also label any unknown devices with our names for easy identification. If you have any questions while the presentation is ongoing, you can put down the chat box. Or the presentation, you can raise your electronic hands so that you'll be called to ask your questions and make contributions. So I recognize all our consultants that have logged in, our trainers, so as not to run behind schedule. Usually our trainers to this important academic session. Dr. Akindele, Dr. Akitade Adeboye, you can share your screen now while we commence the program. Thank you. Dr. Adeboye, your screen is not sharing yet. It's not showing yet.
Oh, I'm doing, sorry, it went off. I'm doing that again. I'm sorry, apologies.
Please share. No problem. Not showing yet. It was showing before. Did you make any adjustments?
I believe you can see my screen
on.
now.
It's coming on, not yet. Okay.
Can you see my screen now,
Okay, you can start. You have 30 minutes. Yes, it's showing. I will not want to interject you while the presentation is going. So you have 30 minutes for your presentation. Thereafter, we'll welcome questions, contributions, and all. Thank you.
Okay. Good evening, everyone. Standing on the already established protocol. My name is Dr. Akintade Adegboyega, senior registrar in the Department of Anaesthesia and Intensive Care of Federal Medical Center, Butemeta, Lagos. I will be presenting the topic anesthesia management of the polytraumatized patients with a systemic approach to initial resuscitation and definitive care in a patient with challenging airway and hemodynamic stability. Thank you. The topic will be discussed under the following outline: definitions, introduction, initial management as the HLS approach, anesthesia management proper, special consideration, conclusions. Objectives. Sorry. Initial, because I'll be using a couple of abbreviations in the course. I would love to run through them. DCR, that's damage control resuscitation. DCS, damage control surgery, which is also a component of damage control resuscitation. Traumatic brain injury severity score, the GCS, glioblastoma scales. What does hypoxia mean? That's partial pressure of oxygen less than 80 millimeter mercury. Then hypoglycemia, abnormal low level of glucose in the blood. That's usually typical less than 3.9 millimole per liter or 70 milligram per dl. Hypokalemia, that's abnormal high level of potassium. That's level above 5 millimole per liter. Others include what hypothermia means, that's temperature less than 35, that's the core body temperature less than 35. Cerebrovenous catheter, USG, which means ultrasound, ultrasonography, ABG, arterial blood gas, venous gas, then TEG and ROTEG, which means thromboelastogram and rotational thromboelastogram. PCI now, these are the closing factors and their various values. Okay, objectives. Our objective today is to ensure that by the end of this presentation, the audience is able to define what polytrauma is, understand what is a triad of death, and they'll be able to outline the anesthetic assessment priority, using primary and second survey approach, then develop a rational strategy for induction, maintenance, and monitoring of anesthesia in the polytrauma patients. Identify and manage common physiological challenges, such as hemorrhagic shock, traumatic brain injury, coagulopathy, and understand the principle of damage control resuscitation and damage control surgery. Polytrauma is defined as an injury. Sorry, polytrauma is defined as. Sorry, is my screen showing, please?
Yes.
Okay. Oh, because I'm using my second phone.
You are on outline.
No problem. Okay, let me go. Okay, yeah. Polytrauma is defined as injury to two or more body regions with at least one of the injury or a combination of the injuries being life-threatening, and usually defined by injury severity score of greater than or equal to 15 in one of the systems or organs, and usually associated with significant physiological derangement. It is the primary leading cause of the leading cause of it is usually by high energy mechanisms such as fall, road traffic accident, and it's the leading cause of death in patients, the most productive age group, as age between 20 to 45 years old, and there is associated with high mobility and mortality. And of course, it's common in males because male, and of course, because of the behavioral associated, as it is said to be high energy mechanisms. And of course, the concept of golden hour concept, which was defined, though there are various schools of thought which talks about golden hour, and even that it's even extend beyond the golden hour. More information will be shared on that to help us understand why the concept of golden hour come into play. It must be said that the management of polytraumatized patients is a multidisciplinary management. As highlighted by the slide, the anesthetics is in the team, the nurses, the surgeons, the emergency physician, the neurologist, and other members of the team. The hematologist, microbiologist could be called upon at various points in time. Our role as anesthesiologists, we play a key role in the management of a polytraumatized patient. And one of these multiple roles include, but not limited to, our role as a perioperative physician, as the airway manager, the leader of the resuscitation team in the operating room, physiologists, metabolic experts to correct temperature, coagulation, and acidic balance, and also a pain physicians to provide multimodal analgesia to a polytraumatized patient. The pathophysiology, or among the terms I will be defined before going to discussion proper, is the term second heat phenomenon. What is second heat phenomenon? To understand second heat phenomenon, I will separate first heat from the second heat phenomenon. The first heat phenomenon, The first heat phenomenon is the initial, just as the name entails, initial traumatic insult causing tissue damage and hemorrhage, such as following fall or trauma or any maybe multiple attacks of that. The initial traumatic insults, which cause tissue damage, inflammation, hemorrhage, and bleeding, is known as the first hit. But the subsequent response, which may necessarily or most times is not usually due to an external trauma, is what is required to as a second hit phenomenon. It could be iatrogenic in origin, such as from our inadequate resuscitation of the patient, in which they may develop hypothermia, hypotension, or maybe excessive crystalloids, such as excessive administration of normal saline, which could make the patient develop hyponatremia. There could also be traditional coagulopathy or other pathologies as a result of our resuscitation, either inadequate or excessive resuscitation, or even the normal cause, such as the transfusion-associated circulatory overload, transfusion-associated liver lung injury, and etc. So this diagram is just a skeptical schematic diagram describing and illustrating the first hit and the second hit phenomenon. From first hit phenomenon, there's initial tissue damage as mentioned, hemorrhage, hypoperfusion from bleeding, shock may arise, and of course, trauma-related factors will cause acute coagulopathy or shock. Then we start our resuscitation. We may end up causing hemodilution, transfusion of stored blood, or inadequate resuscitation, lactic acid, the later triad of mortality, or later triad of death, which we'll talk about later on. And of course, then the second is phenomenon, which could be, like I said earlier on, will be due to the maybe early major surgery, which will now there be increase in the inflammatory response and activation of the systemic inflammatory response syndrome, which will now make the patient prone to infection, which leads to sepsis. Then MODS has multiple organ dysfunction, ALDS, and even death of the patient. It should be noted that the death from the second phenomenon is usually instant. It may be delayed from days to weeks or even months after the individual has been overwhelmed. So the next is talking about the trimodal distribution of death. Oh, I'm sorry, there was an image here. I will share one of the trimodal distribution of death. As described by the Tonki and Baker in the late 1970s and early 1980s, states that there is immediate, early, and late distribution of death, depending on the mechanism of injury, extent of the injury, the site of the injury, the patient's comorbidity, or the existing state of health. The immediate is usually from seconds to minutes, usually involving major vascular structures in the body, and major vascular structures in the body, and typically affect the spinal cord, the brain, and maybe major laceration to the inferior vena cava, aorta, or other things that involve significant bleeding, which can result in death of the patient within seconds to minutes. The early diagnosis is from minutes to hours, which could arise from hypoxia, hypovolemia, or expand hematoma such as in occult bleeding resulting from blunt trauma. And that is where the concept of the golden hour, which means that the quick intervention of such things that may cause death, not immediately, but maybe within minutes to hours. That is the essence of the golden hour. Mitigate the impending death. Then the late, usually, as stated earlier, from days to week, and usually from sepsis, multi-organ failure, malnutrition, etc. So the management of the polytraumatized patients, such as every other emergency, it starts with the ABC of resuscitation using the ATLS approach, which we start from the primary survey, then the secondary survey. What does the primary survey entails? It entails using the ABCD of resuscitation, acronym, airway with C-spine protection, in which the patient is assumed something. It is essential when the patient is fully traumatized to assume that the patient has a cervical spine injury until proven otherwise. We introduce neck collar, and if there is need to protect it, if the airway is not patent, we need to intubate the patient. Manual inline stabilization is adopted for intubation. Breathing and ventilation. Components of associated with multiple trauma could be conditions such as flared chest, massive pneumothorax, or tension pneumothorax, which can ultimately cause patients respiratory embarrassment. So there may be also be need for us to relieve this by quick intervention, at least or temporary intervention by needle thoracotomy initially, and then maybe later on, then definitely later on by chest tube insertion. And this should be done before induction. And then the C is circulation, which is hemorrhage control. We want to monitor the patient's vitals, assess initially the non-invasive blood pressure, heart rate, monitor pulse signs, and identify the source of bleeding. Then this stands for disability, more or less the neurological status, usually assessed with rapid GCS assessment, which will be continuous, pupil size reactivity, and there is need for us to rule out other correctable causes of coma. As a patient who is involved in a traumatic incident, may be having the primary cause of the loss of consciousness may not necessarily be the trauma itself. Patient might have been fasted, which could have even lead to the trauma. Patient may be having an hyperglycemia or other biochemical abnormalities. So it is necessary to rule out those correctable causes of coma. And then exposure and environment. You need to fully expose the patient to identify injuries, then cover with one blanket to prevent hypothermia. As hypothermia is one of the things, component of the triad of death. This is sequential and simultaneous, and problem as they are found. It's not so. Just a schematic diagram showing the basic airway breathing, cardiovascular ventilation. You need to maintain hemodynamic stability. So starting from the airway management, there could be various indications to give the patient a patent airway, such as if the patient doesn't have one, it could be from airway obstruction, or patient with GCS less than 8, patient with severe hemorrhagic shock, respiratory failure, agitation, or patient that will definitely benefit for surgery. Emergencies or trauma cases are usually taken as full stomach, and the key principle is to ensure rapid sequence induction and with manual inline stabilization. Pre-oxygenation done if possible with 100% oxygen for 2 to 5 minutes. The apnea oxygenation is considered, the use of pressor or vasopressors is used. And because patients will be having hemodynamic challenges arising from various causes, the induction agent of choice is usually preferred is ketamine, as it is associated with hemodynamic stability. Etomidat is an alternative, but the challenge with it is because of the suppression of the adrenal gland. We want to avoid propofol because of because of the hypotension in such patients, or hypotension rather, and the muscular blocker of choice is preferred, usually rocuronium, but if not available, Soxamet. So okay, Soxamet could be the agent of choice at just of 1.1 to 1.5 milligram per kg for its rapid onset. But when there are contraindications to such, rocuronium is can come handy. And of course, there isn't for us to plan for a difficult airway, usually with a video laryngoscope and surgical backup, such as the front of neck abscess or other alternatives. The challenges, part of our challenges is that for trauma, as mentioned earlier on, and one of the frequently injured part of the body in the polytraumatized patients, usually the head and the neck. So we should anticipate a difficult airway, which could be from facial trauma, airway hemorrhage, spine instability, or swelled airway. So hence we should have various strategies. That's strategy A, B, C, and D, as mentioned earlier on. With plan A being the rapid sequence induction with manual inline stabilization, where it's plan B being video laryngoscopy, then C, supraglottic airway. After, well, there has been failure to maybe failed attempt at establishing an airway, of course, there is need for us to ensure continuous ventilation in the patient. It is said that failure to intubate is not a problem. I mean, failure to intubate may not be a problem, but the failure to ventilate a patient would actually lead to catastrophic and undesired outcome. However, despite that, there isn't for us to spray a designated airway, but if it failed or among paramedics who may not have the skills for intubation, the supraglottic airway may be adopted. Then the front of neck abscess, that's the surgical cricothyroidotomy or percutaneous ones, could be employed. As anesthetics, we are usually trained to use um, that's the front of neck front of neck access. The most important thing is to ensure patients can be ventilated. Breathing and ventilation. Common thoracic injuries affecting ventilation include tension pneumothorax, which we need needle thorax consistencies as mentioned. Others are massive hemothorax, flared chest, pulmonary contusion. Ventilator strategy in such patients include lung protective strategies, which include use of low tidal volume, reducious PEEP, etc. The essence is to ensure and to avoid worsening lung injury in the patient. The other challenge associated with these patients are hemodynamic instability and shock. The various types of shocks can be present in a patient with polytrauma, usually hemorrhagic, which is as it entails, involves hemorrhage, significant hemorrhage, bleeding, and it is the most common. Then we have the neurogenic from arising from spinal cord injury, usually high level above T6, cardiogenic or the tension pneumothorax, which can be from cardiac tamponade resulting from blunt trauma to the chest, injuring the pericardium covering of the heart. The clinical signs of shock include tachycardia, hypotension, cool, clammy skin, altered metastasis, and low urinary output. However, it should be of note that some of these signs will not be typically, there's no one can fit all. As in the case of neurogenic shock, which unlike others, there is usually vasodilatation arising from loss of vasomotor tone to the vessel. The patient will manifest with vasodilatation. So in such a patient, the skin will not be cool and clammy, instead it will be warm and it may be bright. It will not be cool and it will not be clammy. And of course, because of the unapproved unopposed parasympathetic stimulation on the effect on the heart too. There will be bradycardia as opposed to other ones. Definitely, other ones to have their peculiar signs and symptoms that we can see. Cardiogenic shock, the Beck's triad come into play, as the extended neck vein, the muffled at sounds, and of course the hypotension, of course the internal tension in motor activity is associated symptoms, signs and symptoms too. As mentioned, okay, as mentioned earlier, the goal, the reason for us, and it is essential for us to ensure circulation and hemorrhage is controlled. As failure or delay in doing this or mismanagement during this course could lead to the activation of the letter triad or the triad of death. The schematic diagram is in the next slide. And the components of the letter triad include hypothermia, acidosis, coagulability. The shock, there
was
hello?
one round where you have some, I don't know,
Somebody is talking. I don't know the person interrupt. There's a voice.
they call
Can
me
I
like that. Death. So on your left.
Hello, ma. The woman I mentioned left. Your mic is unmuted. Please kindly mute, ma. So signs of shock listed. It is important to assess why large bore IV access, and when it is difficult, intraosseous access may be considered. So it is worthy of note to state that the central line is not the ideal IV access because as defined or as from our deductions from the Hagen-Poiseuille's equation, the central line catheter is longer length and has a shorter the luminous shorter diameters. So it is not the ideal. But of course, if that's what is obtainable, we have to maximize that. Pending the time, we'll be able to establish other alternative accesses. And a component of our circulation and hemorrhage control also include what is called damage control resuscitation. Damage control resuscitation include the cervical arrest of breathing and maintaining intravascular volume, and also what is called damage control surgery. Damage control surgery is not definitive. It is just like a limb saving or the life saving procedure. And damage control surgery includes early hemorrhagic control, resuscitation, but we have to move away from aggressive traditional crystalloid aggressive resuscitation. With our goal to ensure that the systolic blood pressure is between 80 and 90, so as to ensure organ perfusion. However, in cases where of traumatic brain injury, our target will be to guide for mean arterial pressure to be greater than or equals to 65, as against using systolic blood pressure of 80 to 90. There is need for urgent activation of the massive transfusion protocol as to give blood components that are needed in ratio 1:1:1. That's one for blood products, usually one for packed cells, one for fresh frozen plasma, and two for platelets. And one for platelets or 1:1:2. But in resource poor settings like ours, we have reasons to adopt the 3:2:1. That's three packed blood cells of three rather, fresh frozen plasma of 2, and platelet of 1. As mentioned earlier, one of the goals or the primary goal of that resuscitation is to avoid or prevent and manage the letter triad of the trauma. The component of the letter triad of trauma includes hypothermia, acidosis, and coagulopathy. Hypothermia causes impaired coagulation and cardiac dysfunction. And of course, as we know, with impaired coagulation, the hemorrhage will be more significant. And with impaired cardiac dysfunction too, they will be impaired. Sorry. With hypothermia, there's impaired coagulation, which will lead to more bleeding and make the case worse. Then the impaired cardiac dysfunction too, as well with hypoperfusion, and ultimately lactic acidosis is accumulated. And this acidosis on its own again causes reduced cardiac contractility and also impaired coagulation. And the coagulopathy too, as well with ongoing hemorrhage, it wasn't the shock. And the shock is as well with acidosis. So as you can see, the three of them are linked together. And hence they name the letter triad of trauma or the triad of death. So the our goal is to ensure that we abort or we intervene to prevent initiation of this triad of death or to prevent, and if it has started, to abort it. So the next slide we'll be talking about is the management, basically, of preventing it. The For the hypothermia, there is need for to ensure the patient is placed in warm room, covered with warm blankets. You can make use of 4-year warmer, fridge warmer, and humidified circuits. As mentioned earlier on, the consequences of hypothermia is coagulopathy and arrhythmia. For the acidosis, to treat the cause of the acidosis by giving resuscitation and oxygenation. Then the coagulopathy, we want to, as early as possible, to treat empirically with the multiple transfusion to the use or adoption of massive transfusion protocol and to guide ourselves with the thromboelastogram or rotational thromboelastogram and based on the result of this, we can give the patient a fresh frozen plasma, cryoprecipitate, fibrinogen, or triazemic acid as needed. This is like talking more about what I explained earlier on. 80 to 9 for our target for systolic BP, but with patient with traumatic brain injury, which is even the commonest component of the polytrauma, is to ensure the mean arterial pressure of greater than 80 millimeter of mercury onto the surgical control of breathing. As high blood pressure will easily dislodge clots, blood clots are forming and lead to more bleeding. We have to avoid excessive crystalloid, avoid diluting clotting factor. And of course, other things not yet mentioned before now, use of tranexamic acid, and the goal is to use it within 3 hours of surgery, usually 1 gram bolus over 10 minutes slowly, as there's associated side effects if given rapidly, and then 1 gram infusion over 8 hours, then we give it 8 hourly. Then to ensure it will not make sense if we allow bleeding to continue while we continue to give the patient blood. It's because that may precipitate the massive bleeding, which will ultimately make us massively transfuse the patient with his attendant complications. So there's need for rapid hemorrhage control, such as use of tourniquet if on limbs, hemostatic dressings if it's on the abdomen or other part of the body, pelvic binders, and the use of damage control surgery as soon as possible. Monitoring includes the use of arterial line for beat to beat, as the patient thermodynamics could vary widely within a short period of time. Excessive VP central venous pressure is not reliable. We should consider using the stroke volume variation or the what do you call it, transophageal, sorry, to use the transophageal echography, okay, to use the systolic volume variation, rather. So, okay, I'll mention this. Okay, our target is hemoglobin of, say, that's 7 to 8 gram per DL. And INR international normalized ratio less than 1.5, with fibrinogen between 1.5 to 2 gram per liter, and platelets greater than 50 to 75 gram per DL to maintain normothermia and to maintain normocalcemia. For the monitoring, it includes both the standard American Society of Anesthetic Monitor and with extras. The extras are the invasive arterial line for B2B, frequent ABG, which could with lactate level to which help us to know the adequacy of perfusion and resuscitation, hemoglobin, electrolytes. There will be hyperkalemia when there is massive polytrauma with massive muscle breakdown, and the hyperkalemia can be of delirious consequent effects on the heart, which can as it can cause cardiac arrest. Then central venous pressure is a trend that is trends which means you should look at the variation, not just give absolute value. The point of care testing, such as the thromboelastogram and rotational thromboelastogram, the use of echo to assess volume, status, contractility, and to check for cardiac tamponade, temperature, there's need for active warming, using force air warmer, and also, of course, also to monitor the patient's core body temperature. One other monitors include the urine output with our goal. Usually 0.5 mil, minimum, not less than 0.5 mil per kg per hour in adults, and then serial IBG to give us serial lactate and base deficits. This is okay. Others, radiological investigations include the use of the FAST, that's the focused, sorry, use of the FAST that's focused sonography in trauma. Um, and the components of FAST include the lateral cervical spine, lateral cervical spine of the neck view, a, an AP view of the chest, on the AP and the anterior posterior X-ray of the pelvis. Then CT scan can also be used for the for the each part. That signifies or denotes what it is called the extended fast. Apart from the basic things that the fast shows, the fast or the extended fast have additional two components. The basic components of the fast include use of ultrasound to check the right upper lung quadrant, that's the perihepatic, to the left upper quadrant, that's the perisplenic, the subcostal, that's the pericardiac to check for possible bleeding from the heart region, then pelvic to assess the area behind the bladder. The additional extended one adds two more view to the standard fast, and this to detect pneumothorax as in pneumothorax and possible associated atelectasis, and also bleeding to the thoracic cavity called hemothorax. For it can be of challenge, management of anesthesia management of patient polytrauma, as a lot of time patient could be unknown, but we should try to get as much information as possible from witness and bystanders and bystanders about the patient to ask about the mechanism of trauma, if it is blunt or penetrating, if it's high or low energy, and activate the problem, followed by the secondary survey, then towards preparation for the study, they look for adequate activity, such as use of the acronym AMPU as we used for emergency history taking. Components of history is AMPU, that's used an acronym that stands for allergy, medication history, past medical history. Um, AMPU stands for allergy, medication history, past medical history, then an examination in the patient. Right. For the anesthesia management proper, as you said earlier on, patients usually unknown, often with no past medical history, no history of fasting. The medication history may not be known. Of course, there are as many information that we can get from the patient or from the bystander is usually done. Then we'll be followed by focused examination of the airway, listen to the breath sounds, check for obvious injury, and then do neurological assessments. Then we want to carry out the point of care investigations, such as the arterial venous block. That's when the arterial blood gas is not possible, to check the patient, the baseline hemoglobin and hematocrit, to check the coagulation factors, electrolytes, then the fast scan too. Then for management of these patients, the in perioperative or during intraoperative or during anesthesia, the key or the goal here is preparation. It is essential to ensure anesthetists and members of the resuscitative team are adequately trained and have frequent drills on how to manage emergencies and other emergencies, which include polytrauma. And also apart from also the adequate training, there's need for the trauma cockpit or the anesthetic cockpit to be routinely done to check for airway for various things such as things needed to manage to establish a airway, to ensure at least two working laryngoscopes with blade of various sizes, prepare for difficult airway, ensure there's video laryngoscope, multiple ETCT of various sizes, bougie, supraglottic airway device, and also to ensure the surgical airway kit for glucose aerotomy is available. Drugs that will be needed for the patient, such as induction agent, the paralytic, the sensitive agent, and vasopressors are available. Fluids should be ensured to be available. Warmth, as we want to prevent food in this patient. Rapid diffuser for rapid transfusion. Blood products should be ready and matched. And the monitoring, as stated, include the basic and the standard American Society of Anesthetic basic monitor, which includes the non-invasive blood pressure, pulse oximetry, ECG, and for interpreted patients, the encapsulography. Then the plus, which include the arterial line, ultrasonography, temperature probe in place. There's need for adequate team briefing and assign roles to each person, to each members of the team. The into the mechanism or the principle or the preferred intubation technique in the patients with polytrauma, usually the rapid sequence induction, as it should be assumed that patients with trauma are full stomach. So our goal is to secure airways swiftly while minimizing aspiration risk and hemodynamic insults. We should proximate to patients 3 to 5 minutes with 100% oxygen and consider apneic diffusion of oxygen. Induction agent, as stated earlier, is preferred is ketamine. Etomidate will be used for its delirious effects of suppressing the adrenal gland. We want to avoid people falling in shock. For fast neuromuscular block, broocodon at a dose of 1.2 milligram per kg can be used, or succinylcholine if there is no contraindication to use. Manual inline, manual inline submission is adopted, the patient's collar is removed, and colleague holds head in the neutral position. Frequent pressure, use of frequent pressure is controversial, as it is believed that it may obscure or makes the laryngoscopy more difficult. With induction of anesthesia, okay, yeah, this is just, I'm sorry, for maintenance of anesthesia, the goal is to maintain a balanced technique with the use of low dose volatile agents, such as sevoflurane at at minimum alveolar concentration of less than 1, or TIVA could be employed, or total intervention anesthesia could be employed with use of ketamine plus or minus dazolam. The goal, as we mentioned, is to ensure hemodynamic stability and neuroprotection. Propofol from remifentanil can be used, especially in severe brain injury, to control intracranial pressure. There's a propofol and ketamine can also be used for maintenance once hemodynamic stability has been attained. The opioid use should be minimum to be of minimum, and we want to avoid long-acting agents as they may affect the patient's neurological status. The goal here is not to ensure adequate anesthesia, but to ensure adequate perfusion. In trauma patients, hemodynamic stability comes before ensuring anesthetic depth. And of course, trauma and accidents are one of the risk factors for awareness under anesthesia. Mom, remifentan, short-acting opioid, is employed to blunt sympathetic response at the point of the intubation. Muscle relaxant is used to maintain paralysis for subjects and also to reduce oxygen consumptions. The monitor under anesthesia stated there includes the standard monitors and essential if patient is intubated is the end-tidal CO2. Other additional advanced and invasive monitors include the arterial line for beat-to-beat blood pressure. Frequent EBG is used to assess and control as necessary. Central venous pressure is used when giving the patient vasopressors and not to measure the central venous pressure, even though it is said that the stroke volume variation is more important a, than the static value. Other monitors include the use of the thromboelastogram or rotational thromboelastogram, which is a bedside test and can be done for the patient, which is a point of care testing rather, and it employs the principle of the viscoelastic property of platelet formation, and it helps us to assess which component of coagulation is inadequate and there is inadequate and that is the necessary intervention. Others include the use of echocardiography to assess volume status, contractility, tamponade, temperature is also mentioned, and then of course, traumatized patients to be associated with abdominal compartment syndrome. So there will be need for us to also monitor the bladder pressure. Of special considerations in trauma patients include the following. Traumatic brain injury. It is essential for us to avoid hypoxia and hypotension, to maintain the cerebral perfusion pressure, maintain normocapnia, that's the partial pressure of CO2 between 35 to 40 millimeter of mercury, and osmotherapy, such as the use of mannitol or hypertonic saline, can be used to reduce the intracranial pressure when necessary, when indicated. For chest trauma, we need to be vigilant for pneumothorax, hence we should ensure low tidal volume and employ other lung protective strategies. For abdominal compartment syndrome, I mentioned earlier, to monitor the bladder pressure and to activate the massive transfusion protocol as soon as possible. However, we should beware of the transfusion-associated circulatory overload, transfusion-related acute lung injury, hypocalcemia, hypercalcemia, and other complications associated with massive transfusion. Our goals during the management is to prevent secondary brain injuries, to avoid hypoxia, to ensure the oxygen saturation of greater than 90%, with arterial partial pressure. To ensure, I'm very sorry about that. To ensure the partial pressure of oxygen greater than 100 millimeter of mercury, to avoid hypotension with our target systolic blood pressure between 80 to is greater than 80 to 90 millimeter mercury, and in patients with traumatic brain injury, to ensure mean arterial pressure of greater than 80 millimeter mercury, to maintain normocapnia at the partial pressure of oxygen of CO2 of 35 to 40 millimeter mercury, to hyperventilate to reduce the intracranial pressure and thereby preventing acute annihilation, which can lead to brainstem dysfunction or death, to manage intracranial pressure with mannitol or hypertonic saline, and or head up, or put the patient head up in the supine. If the spine is cleared and the C-spine injury is ruled out, the adequate depth of anesthesia is necessary at the point of intubation to avoid hypertension and covering the patient. However, during the maintenance of anesthesia, it is said that as that hemodynamic stability is prioritized over adequate analgesia. Postoperatively, there is it is no patient with difficult airway will need the operating room extubated and in post preferred in polytrauma patients. I'm sorry, I'm on call. I'm in the call. So the destination of the patient, depending on the status, can be the intensive care unit or the operating room. But it is always better to take the patient to a minimum of HDU for close monitoring. Then the need for to plan for ongoing resuscitation, rewarming and correction of coagulopathy, ensure adequate analgesia, multimodal analgesia, and neurological assessment. We should ensure a detailed summary at handing over of the patient to the ICU team, which include details of the injury, the mechanism of injury, the procedure, any possible intraoperative events, the medications used, blood products that are given, and our plan and recommendation postoperatively. For the takeaways, our key takeaway here should include that there is need for the team to adequately prepare equipment and also for equipment to ensure adequate preparation of the key equipment and medication. To prioritize the ATLS protocol, the ABCD approach, to protect the airway with the planned stage approach, to resuscitate with blood products early and in ratios to mitigate the triad of trauma and to penetrate effectively with the entire trauma team so as to ensure the and to so as to ensure the patient so as to increase the patient's prognosis. In summary, important to ensure that there is team sport. Anesthesia is central to the multidisciplinary team, and as mentioned earlier on, to ensure BC of resuscitation is followed, to break the triad of coagulopathy, to ensure that the damage control resuscitation is done, yeah, with its components, if necessary, damage control surgery, and to plan for the worst case scenario and have a structured plan with it, and to prepare for the difficult airway for the worst hemodynamic instability, and to manage and to be prepared for the specific injuries such as the traumatic brain injury or the hemopericardial or the what they call cardiac component or pneumothorax as it may be. The goal is to get the patient to definitely surgical control and into ICU stable and alive. The following are my references. So thank you very much. In the picture showing the breathing at the stomach unit. Thank you for listening. Questions and contributions are welcome. Thank you.
Thank you. Thank you very much, Dr. Adeboyega Kintade, a senior registrar from FMC Ebutimeta. Before we go ahead, please permit me to introduce some of our trainers that joined during the session. We appreciate your presence, sir. Our present president, NSA, Professor Alassane Dati, immediate past president, Professor Alagwe, our lead, Dr. Aduke, Dr. Ikotun have been with us. Thank you, Ma, since beginning to now. Dr. Adnion, Dr. Echo, Dr. Ogare, Dr. Amola, Dr. Enya, and all consultants present. We appreciate your presence with us. Of one of our trainers, also a board member of World Federation of Society and Professor Elizabeth. Thank you, Ma. So, sir, welcome. We are your presence. So before I give the floor to our teachers, our trainers for contributions, clarifications on this important topic, I want to just summarize the presentation. Dr. Adeboyega Akintade started the presentation with giving us the objectives of polytraumatized patients. He introduced the topic and he gave definitions as medical problem treated injury. And then when we multiple trauma involves 2 or more injuries in the same system, while polytrauma is injuries to 2 or more organs or systems. Then he talked about our concept, that's the critical intervention, which plays significant impact on the outcome. He talked about polytrauma patients involve multidisciplinary management and that anesthetists play key roles in polytraumatic patients. Then talk about the second heat phenomena, the first heat phenomena, the trimodal distribution of deaths, talking about the immediate seconds, the early minutes, and the late days to weeks. Then it took us to the ATLS approach to management of polytraumatic patients and challenges with polytrauma patients, all the enlisted anesthetic considerations before talking about the pre-hospital intervention, upon arrival to hospital intervention, primary survey involving the ABCD of primary survey of ATLS, then secondary survey with ample history and then evaluation before definitive care, and then anesthetic consideration for trauma patients, where he talked about pre-induction care, the induction, the maintenance, the monitoring, intra-op, and post-operative care of polytraumatic patients. Then he shared his responses with his references with us. So before we go to the chat questions, I'll go to, if you have questions, you can put on chat box, and if you have contributions, you can put there as well. Before I hand over the moderation to our trainers consultants that will help us with some of the answers, if Dr. Akizade can answer it, and more clarification. Thank you very much. There's no question yet. Residents, any unclear or even contributions might not have touched some areas that you know about management of polytraumatic patients. So anyone wants to ask questions or contributions, please on the chat box or you raise your electronic hand. Okay, I can see. Thank you, Dr. Akintade, for wonderful presentation. So I cannot see any hand raised electronically. Okay, sorry, 2 hands raised. Dr. John, then after Dr. John, I'll call Dr. Oduma. Dr. John, your hand is down. So Dr. Belima Oduma, please, your contribution or question, sir.
Good evening, everybody. Am I audible? Thank you very much, Dr. Akintade, for the presentation, and good evening to our trainers in the building. I want to also, first of all, commend you for the presentation. So I have a few comments. One of them is I understand that you were trying to be very elaborate with your presentation, but I think the emphasis of this topic is more on I don't know, maybe a patient that is polytraumatized is coming for like surgery. So yeah, you try to talk about the resuscitation parts and stabilization then, but you really didn't dwell more on the anesthesia part of this presentation. Well, I think maybe constraint of time that affected that. But I just wanted to stress on the fact that this patient is actually a multidisciplinary approach. Then I didn't hear you talk about preemptive analgesia for this patient, even from the emergency room. because definitely patients will be in pain even while preparing for whatever resuscitation and stabilization or preparing for surgery. Then as well as even the use of for the preempting anesthesia, multimodal anesthesia blocks can also help with this kind of patient, like patient that you are ruling out maybe chest injury or um, other limb injuries. That could also help to stabilize the patient. Then the role of you actually drilled very well on the role of the transfusion protocol, but emphasis has to be raised on that based on the challenges we have in this society that we are. How sometimes patients will need blood and they will not be able to get blood and blood products, but when the multiple team is actually set up from the emergency, everybody knows their role, and these people could be alerted for these protocols, especially when the patient needs emergency blood transfusion. But in all, it was very, very interesting presentation. Thank you very much.
Thank you, Dr. Belima. Dr. John, please unmute. Let's make it snappy. We are far
Thank you so
beyond
much.
time. We'll be keeping our trainers
Thank you.
waiting.
All right, good evening, everyone. Dr. John, I'm Senior Registrar, FMC Asaba, Trainee Representative of the NSA. Thank you for the presentation, Dr. Akintade. I think it was very detailed, and I think that's why we, will I say, ran out of time, because there's a lot to discuss in the anesthesia of the polytrauma patients. Like Dr. Belema has said, the conversations are not going to end here. I can already see some comments saying, send the slides to the group. As is customary, we will send the slides to the group and we'll continue the discussion on there. I'm saying so that if there are any questions also, we can take them there. So we give enough time for our teachers and trainers to speak, because the time is already fast spent. So I will take this opportunity to recognize the presence of our NSA president, Prof. Dati. Prof. Dati, welcome, sir. Good to have you here. And I think we would hand it over to our teachers and trainers now, because the time is fast spent. Thank you so much.
Thank you very much, Dr. Afam, and thank you, everyone. I joined very late. I was driving, but towards the end, I got the summary of the presentation by the moderator. This is a very important topic. Now, since I'm not here from the beginning, there are a number of trainers here. There is the Dr. Adesha and others. Please comment on this, because Dr. Adesha, I know that airway management in this kind of patient is very important. You want to say one or two things, please? Thank you.
Good evening, sir. Thank you very much, Prof. And thank you to the presenter and also the moderators and organizers. You're doing a very great job. I think, first of all, I want to commend the work done by the presenter, but to just say that it's good to work on your slides better. Your slides were a bit populated, so it might, I understand that you want to give as much to your colleagues. So for this kind of presentation, it's not bad to have many slides as long as you can run through them in good enough time, but it's good for your slides not to be overpopulated or too many words on one slide. The second thing I want to say is you mentioned something about PICOD, or when you're trying to do it, or if it's getting in your way, then you remove it. So there is SALAD, something called SALAD, which is a suction-assisted laryngoscopy and decontamination. So you can introduce your suction catheter while you're trying to do your laryngoscopy and trying to intubate the patient. So if you go online, you can see the demonstration and the videos. So that way you're not too worried about the fact that you don't have cricut in place. And you're also not worried that while you're trying to secure the airway, then you inadvertently contaminate the lungs. So thank you very much. I also want to say that I know you mentioned other things that can be done in the airway, but it's the most important thing that you know is this is a patient that would likely be a difficult intubation. It's an emergency. They can aspirate, and they are mostly hemodynamically unstable. So all these things must be taken into consideration. And most times when you are trying to secure the airway, especially when you are outside of theater, you are again faced with a strange environment where you might not have all you need to get. So it shouldn't be a patient you should be too much in a hurry, especially if there's no obstruction. You need to be sure that you are well prepared and everybody you need to assist you is around. Many times these patients die as a result of airway issues rather than the primary concern. Thank you.
Thank you, ma.
Thank you very much, ma.
Thank you. Professor Lebema, seeing you've joined, you want to say something. Welcome, ma. Professor Lebema.
I'm trying to unmute myself. Good evening, everyone.
Okay, thank you, ma.
Yeah. I hope you're all hearing me.
Yeah, clearly, ma.
Yes, clear. Okay. Well, I'm sorry I joined late. I intended to join early, but I sort of snoozed off where I was. Well, all I have to say is that, yeah, I'm quite proud of you guys, and I'm encouraging you to continue this webinar. It's important to prepare as a presenter. Do your homework, and like Adesina pointed out, you don't have to crowd too many slides. I mean, some important points. What are the things to be noted for post-op polytraumatized patients? Resuscitation is important. Keep the patient alive. The airway is important, not to get it soiled, and getting the patients to go through the procedure that could be a life-saving procedure. Make sure that fluid and circulation is well maintained, which is very important. And I think in our environment, I don't know what we have right now in terms of plasma and plasma expanders. I know it used to be a problem. I hope it's not too much of a problem these days. It's extremely important in the polytraumatized patients because most times you may not be able to get blood immediately for them to save their life. Well done, and keep it up.
Thank you very much, ma, for the wise counsel. Yeah, so I think the discussion, like Dr. Afam said, the discussion can continue on I'm sure you have platforms where you discuss this. One thing I want to say is that you always try to when you do your primary survey, your secondary survey, you're always looking for what is, you're looking for life-threatening situation and addressing it until you stabilize the patient. Now, there will be specific scenarios to illustrate the polytraumatized patient. You know, this is like an overview, a general guide on how you will approach the management of a polytraumatized patient. So I don't know, Dr. Afam, is there any announcement? Because I know it's 1 hour, we are well past the hour. We know that many of the attendees here are still in theater or have just finished and they just want to finish this and start going home. Dr. Afam, any announcement. Okay. Dr. Afam, he's not here, right? Okay, he's not here, the network. So I want to thank everyone who has taken time to be here. I think we expect another great webinar in the next 2 weeks. It's exam period, but we can still take a webinar, and this will be helpful. So we'll see you in 2 weeks' time. Thank you very much.
Thank you, sir. Thank you, Mr. President, sir. We appreciate all our trainers. Thank you, Ma.
Thank you.
Thank
We
you,
also
sir.
appreciate you. Thank you, and keep doing this great work. Thank you.